We go on to our next speaker, Dr. Lav Kochgaway, who's a senior consultant, pediatric cataract squint neuro-ophthalmology from Netralayam, Kolkata. And he's going to talk to us on pediatric cataract surgery, the right planning for optimizing long-term visual outcomes. On to you, Dr. Lav.
Thank you, ma'am. Thank you for giving me this opportunity. And I would be talking on pediatric cataract surgery, right planning for optimizing long-term visual outcomes. And since the topic is on myopia, and I would be focusing mainly on the how to optimize the refractive outcomes and visual outcomes in cases, and we'll leave the other for a different discussion. So one of the most important factors what we have to do in pediatric cataract surgery, and which is different from adult, is the pediatric biometry because of the poor cooperation and fixation, myopic shift related to normal eye growth and axial length elongation after pediatric cataract surgery, and the post-op amblyopia therapy. So these are some of the things that we need for pediatric biometry, which is a handheld keratometer. And unfortunately, now we get we don't get only keratometer; we get with a axial length measurement auto refractor also, which is not of much use, along with either a contact or immersion. Because if the patient is not cooperating for optical biometer, then we will have to do it under general anesthesia in the OT. And I'll just share one small video of how we do in the OT. And what you can see here is we are not using any speculum for the child when taking the keratometry reading, because that can cause some errors. Keep the eye properly moisturized with a normal saline or balanced salt solution, after which the axial length is taken. And we keep the whole range of IOL with us so that once we get the actual biometry reading, we don't fall short of the IOL. And then we decide on what the IOL to be implanted. So to minimize the errors, the measurement should be taken without the use of eye speculum, as we saw in the video, but to prevent corneal dryness, and BSS should be instilled frequently. After doing this, then what formula to be used? And unfortunately, in pediatric cataract, we are still not there in terms of accuracy as compared to the adult cataract. And reason being, because these are shorter length eyeballs, steeper cornea, higher K reading, and the K reading, especially in the first 2 years, changes very fast. Smaller AC depth. So error in axial length can affect IOL power calculation, which is it increases to 3.75 diopter per millimeter of error as compared to 2.5 diopter in children. Another important issue by why we have not achieved that perfection is the effective lens position, because after surgery, when we are doing a posterior capsulorhexis and anterior vitrectomy, the effective lens position also changes. So some error will be there. We don't never hit the target, but that is not the aim also, because we have to aim at a slightly hyperopic child, and we don't aim for total emmetropia. And as you can see, in children, the axial length measurement in the first 10 years, what you see here is changes from 17 millimeter to 23 millimeter in normal children. And that accounts for maybe almost 10 to 12 diopters if it doesn't correspond with keratometry changes also. Some crude methods are used for IOL power calculation, which I would say should be avoided, because just with axial length, and if we are using IOL power in present days, it may not be acceptable. And another thing is undercorrection. Again, a controversial topic here, because there are various school of thought, like in children with 1 to 2 year, what was prescribed earlier was 40 to 60% of undercorrection. But in these children, if they are not compliant with spectacles, that may induce amblyopia rather than causing any benefit to the child. So normally what we use is either SRKT or Barrett's 2, and Another important issue here is the target refraction, and we generally aim for a small hyperopic correction to balance the myopic shift in the future. But there are other factors also which we have to consider, and which is smaller children, the myopic shift may be faster, and then we have to go for a slightly more hyperopia. Status of the fellow eye, especially if it is a unilateral cataract, it may lead to we may have to balance it with the refractive status of the other eye, and also with the expected compliance with spectacles. Parents' refractive error will give us an idea about the future myopic shift in the children. And if it is extremes of power, then we have to, what I do is generally I limit myself to the IOL power that is available, and especially we don't get IOL power beyond 30 diopters generally. Bilateral cataract is again early surgery. By early surgery, what we mean is earliest what we can do is at around 3 months of age. It should not be delayed beyond that because of the risk of visual deprivation. And what I prefer generally, I space both the eyes around 1 week apart, but there is it can be done maybe 2 to 3 weeks later also. Unilateral cataract, it is a bigger emergency when compared to a bilateral cataract, and the age at which the child has to be operated can be a little earlier also. Choice of IOL, definitely not hydrophilic, sorry, because long term there are chances of calcium deposits in hydrophilic lens. So in children, those have to be avoided. Mainly the current gold standard is the hydrophobic lens, and that can be either a biconvex or aspheric. But most commonly what is used is a biconvex lens, toric in older children, because then the change in refractive error is lesser. EDOFs and trifocals again are matter of discussion. There is still no consensus regarding these IOLs in children. Now, post-op refraction, what we do once the surgery is done, after surgery, post-op refraction, generally we overcorrect for intermediate vision for children, because in preschool children, their life revolves around intermediate vision. And school-going age, then we shift to bifocals as the child grows. When there is a possibility of giving a slightly larger frame, then we can go for progressives. Important topic, and that correlates more with the topic of discussion today, is the myopic shift after cataract surgery, and the factors which generally are responsible is the age of surgery. Earlier the surgery, the chances of faster myopic shift is higher. Unilateral cataracts, myopic shift is higher compared to bilateral cataract. Glaucoma, if there is a abnormal myopic shift, we have to always suspect glaucoma and check the
Doctor, 1 minute left.
Yeah. And use of low dose atropine in pseudophakic children is again can be tried. Post-op care will be amblyopia therapy, as all of us know. IOP check almost at every visit, especially in the first 1 or 2 years after surgery. Frequent follow-up. What I do is generally my early first follow-up is about after glass appointment is about a month after that, and after that every 3 months, and if patching is being done, it can be even 2 months. Constant conversation with parents is very, very important, because they have to realize and they have to be a party to the treatment, because all the implementation has to be done by them. Thank you so much.
Thanks, Dr. Lav. That was a wonderful talk. What is the IOL formula you use?
I mainly use SRKT.
Sir has covered everything beautifully, including whether we can add atropine or not.
Yes.
So as all our speakers have told us, check for axial myopia. If it's a true axial myopia, I think we can start atropine, even in pseudophakics, because the mechanism, as we know, is not the accommodation. It is on the retinal receptors. Thank you.